Good morning, everyone. This is our web show, It's All in Your Head. Welcome, make yourself comfortable, and in a few moments, I will invite Dr. Paul Swingle to discuss today's topic, which is epilepsy and seizure disorders. I'd like to start with Dr. Swingle's background. Dr. Swingle was titular full professor of psychology at the University of Ottawa prior to moving to Vancouver. Fellow of the Canadian Psychological Association, Dr. Swingle was lecturer in psychiatry at Harvard Medical School, attending psychologist at McLean's Hospital in Boston, where he also coordinator of the Clinical Psychophysiology Service. Dr. Swingle is registered psychologist in British Columbia, certified in biofeedback and neurotherapy. His newest book, Biofeedback for the Brain, was published by Rutgers University Press, and the book is available at www.soundhealthproducts.com. Again, that is soundhealthproducts.com. Okay, I'd like to emphasize that we will have 2 break periods during this talk, and we do these to answer your questions. So feel free to send us your questions at any time during this webcast. Just type them in the chat box, which is located on the control panel you can see on your right. There is a chat tab which you can click on, and that opens the chat box. All right, let's start the show. Good morning, Dr. Swingle.
Good morning. We are going to be talking about a really complex issue today, epilepsy and seizure disorders, and we're also going to be talking about another condition that appears to be intimately involved with seizures and epilepsy, and that's autism and the other disorders on the autistic spectrum. There's an interesting relationship among these conditions, and we'll be spending some time talking about these things. We're going to be talking about pseudo-seizure disorders, another very interesting condition. It's now called non-epileptic seizure, and what is meant by that is there appears to be no EEG markers for seizure as you find in epilepsy. We'll be looking at some actual data of somebody going through what looks like it might be a pseudo-seizure disorder, in which you get some important changes in brain activity, but they're not the ones we usually identify with epilepsy. Then we have the absence seizures, and very often they're misdiagnosed as ADD, ADHD, because a lot of it manifests as the child just sitting and going blank. And because a lot of children have the tendency to kind of go blank when you're giving them instructions and so forth, often it's misinterpreted as a volitional condition, or at least a condition associated with problems with sustaining attention rather than an actual seizure. We're going to be talking about medication effects, and this is an extremely difficult situation for people who are trying to medically control seizures because of the very, very serious side effects associated with the anti-seizure medications. And then we'll be talking about one of the more aggressive forms of neurotherapy that we find extremely efficient for dealing with these very serious problems of seizure disorders. And the advantage of braindriving is that we can use neurotherapy with very young infants who are experiencing seizure problems, whereas regular straightforward neurofeedback, brain with biofeedback, is not really a suitable treatment for them because, of course, they're much too young. They're infants. We treat them, 4 months of age for some of these characteristics. Okay. And what we typically do is a full brain map when we're working with a condition of a seizure disorder. And we'll be looking at both the full brain maps and also the more efficient and faster clinical Q, as it's called, which we do in a single session, give feedback in a single session. There's a lot you can tell from a very simple 5-point assessment. But in general, when we have a situation of seizures, we always go for a full brain assessment. Now, the cardinal marker for a seizure problem is elevated slow frequency, and that's what we're looking at here. Anything from roughly yellow up to red is indicative of excessive amounts of slow frequency. And you can see a lot of slow frequency sitting up in the frontal, central frontal regions. And the other feature associated with seizure disorder is a deficiency in what's called the sensory motor rhythm. And that's a brainwave rhythm between about 13 and 15 cycles a second. And the only place you find that is right over the sensory motor cortex, right across the top of the head from the top of one ear to the top of the other ear, roughly. And you can see that a lot of that area is in deep blue, and deep blue means deficiency. So this is a ratio that we've developed for having a look at seizure threshold potential, and it's referred to as the theta-beta ratio. And theta are the slower brain waves, 3 to 7 cycles a second. And we're looking at the amplitude of that slow brainwave band divided by the amplitude of what's called the sensory motor rhythm, which in general are brain waves in the 13 to 15 cycles a second, but you can find it lower in the 10 to 12 range. Now here's another client. This has a somewhat clearer look at that elevated slow frequency and deficient fast frequency. So here's your slow frequency here sitting up frontally and over the sensory motor strip, and then here's where you have your deficiency in that the sensory motor cortex, sensory motor rhythm. So that's what epilepsy is likely to look like. Now, you can actually look at it in terms of the raw signal, and this is what they mean by an epileptiform wave, in which you get a lot of this, it's actually in the alpha range activity, and in this case, it's frontally and temporally. So we're getting it all on the left side and running from the front part of the head over the left eye, running right back into the temporal regions on the side of the head. Now, one of the things that we often find with our autistic kids is that they also have a seizure disorder, epilepsy. And this is a particularly interesting book and particularly interesting case of Adam. And Adam had Lennox-Gastaut syndrome, which is a form of epilepsy. And it's a difficult to treat form of child onset epilepsy that most often appears between roughly 2 years and 6 years of age. And it's characterized by frequent seizures and different seizure types, developmental delays, psychological and behavioral problems, autism, and so forth. Now, Adam had a rather severe condition of Lennox-Gastaut, and very early on, his mother, Arlene, was told to put him in a crash helmet and institutionalize him. Very, very courageous woman. She was going to have none of that. And this is a picture of Adam in a tuxedo graduating from high school. Neurotherapy was central to a lot of what she did, but she did everything. She did diet and all kinds of things. So neurotherapy wasn't the only thing that she applied to this. But this is an article on Adam that appeared in the Peace Arch News. For those folks of you in the audience who are from the BC area, this is a community level news paper down close to the border in the White Rock area. In any event, she talks about how rapidly Adam responded to the improvement in the seizures. And then after about 40 sessions over several years, he was off the diet, and his autistic tendencies had reduced very, very markedly. The exposure to anti-epileptic drugs for mothers, for females, is just recently been, well, we've known for some time that some of them, like valproic acid, there was a high risk of some neurodevelopment disorders associated with when the mother was taking anti-epileptic medication. We see a lot of women who are either pregnant or want to get pregnant, and they have a seizure disorder. And of course, seizure, when you're carrying, can be extraordinarily dangerous situation. So the neurologist is caught between a rock and a hard place here, because trying to get the seizures under control, but recognizing these huge potential side effects associated with these anti-seizure medications. Valproic acid is a common one that's used, and you can see that 12% diagnosis of neurodevelopmental disorders versus control sitting at about 2%. So there's a huge potential here associated with negative effects of the use of these anti-epileptic medications. So there's 6 to 10 times increase in the diagnosis of neurodevelopmental disorder, and primarily autism. The other anti-epileptic medications, all of them have some risk of congenital malformations, and the major issue is reduction in cognitive functioning. Now, the interesting thing is, we're focusing on women who have a potential for seizure, but the off-label use of anti-epileptic medications, most anti-epileptic medications prescriptions are not for seizure disorders, but they're for psychiatric and pain indications. So under those conditions, there's absolutely no justification for using this kind of medication with women who are or intend to become pregnant. And most of the audience are familiar with some of the brain waves, but the slow brainwave delta in the range of 1 to 3 cycles a second is a very slow wave, looks like this, and it's associated with sleep and drowsiness. And then theta waves a little faster. You can see the theta waves here sitting on top of faster waves. And theta waves 3 to 7 cycles a second. That's when people are spacey, inattentive, relaxed. Depends on where the theta is, of course. Alpha is a major, extremely important waveform. Alpha got a bad rep about 20 years ago because we used to think alpha was a relaxation wave. More alpha, the more relaxed you are, and so forth. But alpha is extremely important in terms of immune functioning, processing of emotional trauma, and so forth. And the band wave for alpha is about 8 to 12 cycles a second. And then, of course, beta, which is the fast activity in the brain, 16 to 25 cycles a second or so. And this is what it's. This is a spectrum So these are the fast waves down here, up to 40 cycles a second. And these are the slow ones down here, starting at a half a cycle a second. And this is a nice, healthy distribution. So it's a nice, healthy brain we're looking at here. And the important thing to keep in mind is you want an algorithm here. You want it roughly that amplitude, that is the strength of the brain wave, is inversely related to frequency. So the low frequencies have very high amplitudes. The very low frequencies have high amplitudes. I think I said that backwards. The very low frequencies have the highest amplitude. The very high frequencies have the lowest amplitude. That's what you want it to look like. And this is your raw signal. And here's theta, there's alpha, and there's beta, extracted out of that general waveform. So the common patterns that we're looking for when we're looking at the data associated with people with seizure disorders, or if we're suspicious that we're dealing with a seizure issue, is deficient slow-fast ratio in the back of the brain. Now that we'll be looking at routinely as we're moving through here. That's associated with the ability to quiet oneself. Now, the second thing that we're looking at is too much slow frequency over the central part of the brain, and those were the two brain maps that we looked at earlier. And then the related waveform is low amplitude of the sensory motor rhythm, again over that same area of the brain. And that's expressed as a ratio, and that is the amplitude of theta, 3 to 7 cycles a second, divided by the amplitude of that somewhat faster sensory motor rhythm. We're also going to find that there's an area right in the front part of the brain, and when that area is hyperactive, individuals have difficulty with flexibility in the brain, and we often find this in conditions of seizure disorders, and we'll have a look at that too. And then, of course, straightforward epileptiform spindles, and those are those alpha spindles that I showed you earlier with the full brain map. So the first area here is, and we're looking to see if there's not enough sensory motor rhythm here over the sensory motor cortex on both sides. And we're also seeing if there's a problem with the ability of the person to quiet themselves, and that's taking place in the back part of the brain here. And then the other issue is, do we have an issue associated with elevated activity of a structure that's sitting right in here, the anterior cingulate gyrus.
Thank you, Dr. Swingle. We have our first break here, and we have a couple questions. I know that anti-seizure medications can seriously affect a child's development, in particular their learning abilities. Why are they used? I mean, why are anti-seizure medications used if they cause retarded development?
Well, as I was saying earlier, which is what probably prompted your response here, your question here, there are serious consequences associated with the anti-seizure medication, and I was just talking about the mother here, but the child, if you give the child these anti-seizure medications, you also get very serious potential side effects and developmental delays. Now, flip side of this, just think if you're a neurologist and you are trying to treat a child with a very serious seizure problem, and seizures are not benign things, that are just a nuisance, and you wait till they are over. You can have situations of severe seizure problems in which the child is having 30 or 40 seizures a day, and any one of those seizures can result in death. So when you look at it from that side of the fence, These individuals are caught between a rock and a hard place, as we say, in terms of what are they going to do to try to get those seizures under some degree of control. Now, the flip side of that is we do know that things like specific kinds of diets can be effective. We also know that there's very good evidence in terms of the beneficial effects of neurotherapy, and that goes back 40-some years. So I would add to this that it would be important for the neurologist to have a hard look at what kind of other things can be put in the mix here, that is major diet issues, neurotherapy and so forth, to try to increase seizure thresholds so that they can decrease these high-risk anti-seizure medications.
Thank you, Dr. Swingle. Another question we have here: does epilepsy or seizure disorder develop in the child's brain prior to birth? And what are the factors that cause this?
The answer is yes. I think that's exactly what happens. And the effects of the anti-seizure medication, of course, are occurring prenatally. We also have some pretty good evidence that mothers who have been exposed to pollutants have much higher probability of having children that have diagnoses of autism and learning disorders. And that's work that's been done with families that how close to freeways do they live in terms of traffic pollutants, noise, how close to generating plants they live. So I completely agree with you that a lot of this takes place, during the gestation periods.
Thank you. And last question: can diet affect seizures?
Oh, you bet. And we'll be talking about that a little later on. We'll be talking about one of the diets, the ketogenic diet.
Thank you.
Now, this is these are data of a 11-year-old child who has autism and seizure disorder. Now, the critical things I want to point out here is this is sitting up over the sensory-motor cortex. Now, you remember that's the area right on top of the head going across from top of the ear to top of the ear. Now, we see that there's an excessive amount of slow frequency up there, and that theta SMR ratio that we were talking about earlier is extremely high, sitting around 6. We want that down in the region of under 3 or so. And the second thing, remember we were talking about that area in the front part of the brain, the anterior cingulate gyrus. Here again, we have a situation in which that area of the brain is very, very hyperactive. So there's a perseverative aspect to the child's behavior and a rigidity in functioning. Now, my guess is that is contributing in terms of central nervous system rigidity, adding to the issue associated with seizure conditions. Now, we have a situation of marked elevation of slow frequency in the front part of the brain. F3 is the left frontal part of the brain. F4 is the right frontal area. Again, there's just too much slow frequency activity all over the place. Now, here's a very good example of an extremely difficult problem to deal with. This individual has multiple seizure medication. The seizure frequency is 2 to 7 times a month, and he's experiencing significant developmental delays. Okay? So we have an issue here in which the autism is, of course, associated with cognitive and social delays. We have a situation in which seizures are giving rise to some of these developmental delays as well because of the effects that has in terms of slow frequencies. multiple seizure medications, which is further exacerbating the problem associated with problems with certainly cognitive developmental delays. So this is the kind of complex condition that we see a lot of in our clinic here. First order of business we find is to go after this. That is to get that theta SMR ratio down. We find that if you can increase the strength of the sensory motor rhythm, seizure threshold increases, frequency of seizures decrease. There's nothing new about that particular treatment. That's the one that was discovered by Dr. Sturman, almost 50 years ago now. So we have a long history of the efficacy of that kind of treatment. But there's much more to treating this child than just this. That can help with the seizures, help with reduction of the seizure medications. Then we have to go after the autism. Anti-seizure medication effects, these are what they are. Marked elevation of slow frequency, and that's what's responsible for the developmental delays, particularly cognitive. This is the front part of the brain again, and those slow-fast ratios are sitting up in the region of about 4, and we want it down closer to 2. And the other telltale sign is what happens to alpha. Alpha brainwaves from 8 to 12 cycles a second, and we want more fast alpha, less slow alpha, and this is the other way around. This child has almost 3 times as much slow alpha amplitude as fast alpha amplitude. We want it under 1.5. So there are your markers associated with the developmental delay impact of anti-seizure medication. Now, we were talking about the Lennox-Gastaut syndrome, the form of epilepsy that typically manifests between the 2nd and 6th year of life, and often found with related to autism. That's basically what we were dealing with when we were dealing with Adam. There's some reason to believe that Lennox-Gastaut is related or parallels West syndrome. Now, West syndrome occurs very early in life. You see, this is a 9-month-old child. And this child was experiencing seizures every day. And the theta SMR ratio that we were concerned about was greater than 10. And again, we want it down under 3 or so. So what we were doing here is quite a few different things. One is we were using a procedure referred to as EFT, or emotional freedom technique. That's a technique of tapping on acupuncture points that we teach parents how to do at home. And we found that's extremely effective for increasing the sensory motor rhythm. And there's a very specific treatment protocol we use for that. So we taught the parents how to do that. And you can see that EFT increased the sensory motor rhythm by about 55%. Okay. There was a correlated effect of that, which I'll go into later, where we had to use a harmonic to keep it under control. But this is a family that flew in from the east, Japan, I believe, and the child was having multiple seizures every day. We did the brain driving treatment with this child, driving up the sensory motor rhythm, driving down the slow frequency amplitude, gave him this treatment to do at home. When he started, he had no seizure-free days, seizures every day. They stayed with us for 3 months. At the end of the 11th week, he was experiencing 100% seizure-free days, and he, of course, was medication-free at that time. Neurotherapy is we're often asked to treat difficult situations, and this is an extremely difficult situation to deal with, both emotionally and in terms of neurotherapy. This is a 26-month-old child who had genetic degenerative brain disorder, which is always fatal, and infantile spasms just occur constantly with these children. The typical treatment to this is basically sedate the child so that they sleep until they die. I'm probably overstating that, but that's basically, my emotional state of what I'm thinking about when dealing with these kids. The parents wanted to have a relationship with the child. They didn't want a child just sleeping until they died. And when they came in, the Theta SMR ratio was very high. He had multiple daily seizures, limited use of his arms. So the treatment that we did again was the Theta SMR. We did a lot of other stuff. He also had the problem of elevated activity sitting over the anterior cingulate, so we were treating that as well. They were doing EFT at home, and we were using a harmonic referred to as Mozart, and I'll show you the data on that, excuse me, a little later on. And the Braindriving we often use for some of these young kids, by the way, is we give them a bear, a fuzzy bear toy, and the toy vibrates when the brain's doing what we want it to do. And it really works extremely well with these kids. So the outcome of this, after we did some sessions, was the child was alert, many seizure-free days, regained partial use of his arms, and he died 16 months after treatment. Okay, Braindriving. Now this is the really extremely useful technique that I developed some time ago. And it's a technique that we can use with people who cannot volitionally participate in neurofeedback. The aged, the demented, people in stroke, people in coma, young infants, seriously developmentally delayed kids, and so forth. And this is the setup. It takes many different forms, but basically we're able to present sounds based on what the brain is doing. We're able to present lights. These are goggles that have lights in them, again, depending upon what the brain is doing. We can stimulate acupuncture points. Now, I just want to show you that sometimes it's very obvious if you look at the raw signal, the difference between a child that has this hyperactive condition and a child that doesn't. You can see just a big difference here in the strength of that low frequency. This looks like it's at least double what that is over there. And correlated to that is you often see a decrease or a lower amplitude in the high frequencies relative to that. And the ratio we look at here is the ratio of the amplitude of low frequency divided by the amplitude of frequency, the theta-beta ratio as it's called. And that's very similar to the Theta SMR ratio. Okay. Now, there's a harmonic that we use referred to as Omni. And this is a brain assessment associated with how much change you get in brain waves when the person is exposed to the Omni harmonic. Now, this is the frequency of the brain wave. These are the very slow ones. Remember that alpha runs from 3 to 7 cycles a second. So there's your alpha down in there. Very slow alpha. Remember, we often want to keep slow alpha down and fast alpha up. So this is a very, very nice demonstration of what Omni can do in terms of suppressing all of that low frequency, increasing the faster alpha frequencies. It doesn't do very much in terms of two of the waveforms associated with the sensory motor rhythm, but it certainly increases one of them. So at 14 hertz, we're getting a nice jump. So this would be something that we would use not only with brain driving, but we'd also give it to parents to use at home to suppress the waveforms that and enhance the waveforms that would increase seizure thresholds so that the child would be less vulnerable to seizure. This is data that was sent to me by the late Dr. Budzinski, by the way. On the other hand, this doesn't look like it's so good. This is the same wave, the same sound rather, because you see what happens. Although it's suppressing all that low frequency, it's also suppressing the sensory motor rhythm. Okay, so we want to really individually test this, and this is the testing of the harmonic. That is, what does that harmonic actually do to the brain? So we test it before we use it. Let's see, sensory motor rhythm. Here it is here. What we're trying to do is find out what this particular wave sound, the Omni harmonic, what it does to the sensory motor rhythm and the theta SMR ratio in particular. Now remember, the lower the number here, the higher the seizure threshold. That is, the more resistant they are to seizure. Now this is without the harmonic. So the theta SMR ratio without the harmonic is 4.84. This is when we have the client exposed to the harmonic. That's a huge decrease in the theta SMR ratio. So that's about a 35% decrease in the theta SMR ratio, and that's close to normal range. So we know that if this individual used the Omni harmonic at home, at this decibel level, and we give them a decibel meter so that they can take it home and adjust it precisely to what is the most efficacious dose, that this is what the result's going to be, and we would expect an improvement in seizure conditions. This is a louder presentation. You can see it's not as good as the low one. And here's a louder yet, and you can see, again, it's not as good as that very first presentation, which was at a very, very low amplitude. So this is the precision that we bring to the table with regard to the treatment of seizure disorders. And we can test this generally by just turning it on and seeing what it does to theta. And here's where it's being presented, where the Omni sound is presented, and you can see the drop here in theta amplitude. So we know it's going to work. Here it's not going to work. So here's where the presentation of the Omni harmonic, and it actually made the situation a bit worse. So we know that Omni is not an efficacious treatment for this individual. Okay, so we've been focusing our attention on the sensory motor cortex, the theta SMR ratio as it's called. Now, Mozart, you remember when we were treating the child with degenerative brain disorder, we were using Mozart as opposed to some of the other harmonics. Now, Mozart is a harmonic that we use for artists. Artists play it in their studios because it increases a waveform associated with creativity. We also discovered that it, in some cases, has a beneficial effect on reduction of the theta SMR ratio. And here's a good example of that. Here's a theta SMR ratio, which is pretty high in this child, 6.79, and just listening to that Mozart harmonic reduces that theta SMR ratio by quite a substantial amount. Here's another example of that. And here's the baseline theta, and here's the baseline SMR. So we get a nice decrease in the theta SMR ratio, a nice decrease in the theta, and a nice increase in the SMR, resulting in a nice decrease in the theta SMR ratio. Again, in a epileptic client. So we know it's going to be beneficial. We've tested it before we use it. Emotional freedom technique. This is the one that we use for the little child that had West syndrome. And what it is tapping of acupuncture points. Each one of these is an acupuncture point. Here's on the side of the hand, and you start by tapping this. For little kids, we call it the karate chop point. And then we start edge of the eyebrow, edge of the eye, under the nose, under the chin. K27, as it's called, is under the collarbone. And then 4 fingers down, 4-finger widths down from the armpit. At that location, right in the medial area, is, again, the last acupuncture point. And for the kids, we call it the monkey tickle point. And lightly, and I emphasize lightly, tapping these in sequence will increase the sensory motor rhythm for a large number of individuals. And this is what it looks like. So here's where the individual went through the tapping, and it's a very rapid procedure that you can use. And you can see we get a nice increase in the sensory motor rhythm with just that tapping procedure. Now, this is a child that had very serious side effects from lamotrigine and clonazepam, slurred speech, clumsiness, drowsiness, and so forth. So any kind of this treatment, in addition to neurotherapy now, I mean, but this is not, this is something that the child or the parent does at home for the child. Here's another 14-year-old epileptic. And here again is where EFT was used. And here's the what happens with Theta, what happens with the sensory motor rhythm. So we have a nice decrease in the Theta SMR ratio just with the use of EFT. Now, one of the problems with EFT, here by the way, is just the percent increase in the sensory motor rhythm with clients with various diagnoses, including, of course, epilepsy, a child with autism, depression, fibromyalgia, and so forth. One of the issues associated with the use of EFT is that, let's see here, when you're tapping, what often happens is you get an increase in Theta. That is, the tapping for the emotional freedom technique not only increases the sensory motor rhythm, but it also increases Theta. Now, remember, if you increase Theta, you make the person more vulnerable to seizures. If you increase SMR, you make them less vulnerable. But the problem is if you're doing both, then your Theta SMR ratio may not change. So here's where we use Omni. And remember what Omni does. Omni suppresses Theta. So while you're doing EFT, you're simultaneously presenting or having the child or a person listen to Theta, which is a very efficient treatment. And this is the one that was used by the little child with West syndrome. Sometimes things don't work. Now, here's a procedure we use of stimulating an area on the forearm called pericardium 6. We stimulate it electrically. And it has a nice effect of increasing Theta for quieting. And one of the things that people used to do was to try to relax an individual with seizure problems, because the supposition was a relaxed individual would be less likely to have a seizure. Well, here's some compelling evidence that that may not be true. So we were using this. It increased Theta. It decreased the sensory motor rhythm. So by relaxing this individual, by stimulating pericardium 6, an acupuncture point, we made the person more vulnerable. And here it is right there. Somebody mentioned diet, and this is the ketogenic diet, which is high fat, adequate protein, but low carbs. And it's a very efficient diet, and this is one that Arlene Martell used with Adam, as you may recall. She had him on the ketogenic, and it was very effective for Adam as well. It's effective in about half of the patients who try it, and very effective in 1/3. Very few treatments can boast this kind of success rate. Clear benefit for treating children with refractory epilepsy. And the treatment lasts from 6 to 24 months and frequently results in a 90% decrease in or elimination of seizures. Okay, that's some data that came out in the Journal of Child Neurology.
Thank you, Dr. Swingle. We have more questions here. I'm currently working toward a clinical trial with persons, that is children and adults, with intractable epilepsy. A large percentage of these children are less than 5 years, and others are quite developmentally behind. With QEEG Loretta guidance, how can we best implement neurofeedback in these children?
Braindriving. You can brain drive Loretta feedback. Now, I presume you're doing Loretta guided feedback, is if I understand your question properly. And if you set it up with a brain driver, then you can use a variety of different stimulation conditions, or you can use something like the vibrating bear as your feedback. So this is precisely what we did with the West syndrome and the degenerative brain disorder condition. So it's a very, very straightforward procedure. The problem that we have is people were trying to use regular neurofeedback to treat these individuals. And neurofeedback very often is just not effective because you can't get the child's attention and so forth and so on. It's an operant conditioning procedure as opposed to brain driving, which is a classical conditioning procedure.
Thank you. My son has been diagnosed with ADHD. He seems fine at home, but his teacher says he goes blank. I have heard of seizures that are like this. Can we have a seizure problem?
Yes, that's what I was referring to earlier on, the absence seizure condition, often diagnosed as ADD, in which the child goes blank for a moment or two and then refocuses, and people think that, you know, they're just not paying attention. Excuse me. Now, part of the issue here is the absence seizure may only last for a few seconds. So, you know, the teacher's noticing that Johnny's not paying attention. She says, Johnny, and then she walks over, Johnny, and then walks over and yells, Johnny. By that time, the seizure's over and Johnny reorients. Now, the teacher is making the assumption that Johnny was gathering wool, you know, looking out the window, wishing he was climbing a tree rather than listening to her, when in fact he was having a seizure. And simply because she used up the time by yelling, she makes the assumption that it's her yelling that's refocusing him. So it's very, very possible that that's what you're dealing with.
Thank you. Mike, I'm not sure if I'm going to read your question correct. ONFE has gotten our child seizure-free for years, but we are told it will cease to be effective due to habituation. We were told to expect it to last 1 year. Does this sound like an extended honeymoon? Child has Deuce syndrome and was having 40 to 60 drop seizures a day before.
And I'm sorry, what was the medication?
ONFI? ONFI, I'm not sure. Mike, can you specify the medication?
In any event, there are habituation periods associated with seizure meds, so it's very likely that, if I understand the question correctly, that it is going to be a situation of habituation. Then they have to up the levels, make changes in the medications, and it's never as good, and that's our experience. So your phrase that you're in a honeymoon period, I think, may well be correct. And now's the time to consider some other things, in terms of whether it's neurotherapy, diet. There are lots of ways of going about this now that you have a window while the child is being well maintained.
Thank you, Dr. Swingle. Yeah, Mike is saying that is the generic name for drug, ONFI.
Yes, okay.
Okay, great. Okay, is autism a form of seizure disorder?
Interesting question. We get some conditions that, kind of look like it. But no, I don't think it is a form. I think it's related. So that you're having functional dysregulation in the brain, and that functional dysregulation is manifesting both as seizure and as autism.
Oh, thank you, Dr. Swingle. We are going to have to move on.
Okay, pseudo-seizure disorders. What a pseudo-seizure disorder is a seizure without any obvious epileptiform activity, and is now referred to as non-epileptic seizures. Eclampsia is a form of muscle contraction during delivery, and it's a serious problem associated with delivery. But the only reason I'm showing this is that this kind of response is not really a seizure. This is a different kind of activity altogether. And this is not an emotional thing. The emotional traumas, the trauma-based seizures, what I call pseudo-seizure disorder, is associated with a very identifiable pattern in the brain. Now, this you've seen before. This is the healthy brain. And this is what an alpha response looks like in a healthy brain. Now, this individual's the electrode's sitting over the midline rear part of the brain, and when the person closes their eyes, you're going to see a nice jump in alpha activity sitting right in this region here. The eyes will be closed. You'll get a nice jump. Here it comes. And as soon as she opens her eyes, it will drop like a rock, which is exactly what we want. That's the alpha response. Eyes closed, and then eyes open. There it is. Okay, so that's what it should look like. This is trauma. Now, for openness, you can see that we're getting the high frequencies low frequencies tend to be a little low here. But when the eyes are closed, you're going to see that the brain is making a heroic effort to get an alpha response, but it just keeps getting banged down again. And this is the marker for exposure to severe emotional stress. You can think in terms of post-traumatic stress disorder kind of thing, but much less severe conditions than that, in which the person is carrying around what we call unprocessed trauma. And this is what it looks like. This person's closed their eyes, alpha's bouncing up and down, but it just can't stay strong. Here's what it looks like on the cue. There's where the eyes are closed, and you're not getting any jump in alpha. Here's what it looks like if you provoke a seizure, and this is by just increasing sound and watching the electrodermal response. And when the electrodermal response is indicating increases of arousal, seizures get triggered. Here's an actual trauma release in a clinical context. And what this is this is where an individual may be doing things like tensing up, thrashing, fainting, all kinds of things, but this is what it looks like neurologically, a drop in the amplitude of theta. When we're trying to release alpha, and you can see alpha starts to climb up, bang, we got a trauma release. So you can see the effect in beta, and you can see the effect in theta, and then recovery starts to take place. That's trauma release. That's one of the methods of treatment of pseudo-seizure disorder. You release the trauma associated with the seizure. Now, dynamically what's happening is the seizure is working to aid the client to not experience the motion associated with the trauma. So it's a blocking phenomenon. I did a paper on this for biological psychiatry about 15 years or so ago. If anybody's interested, just drop us a line here and we can send it to you. Okay, here's a situation of post-traumatic stress disorder, which is exactly the kind of thing that's associated with the seizure, except in this kind of situation you can get other kind of frightening kinds of manifestations of it. This is a hospitalized vet with post-traumatic stress disorder. He was at a demonstration in which somebody was heckling. He went home, got an unloaded gun, went out and pointed it at the guy, pulled the trigger. Okay? Police were not at all happy about that. Now, here's what that trauma response looks like, and that alpha should be above 30%. It's going negative. So the treatment of this is to help this individual release the alpha. It releases the trauma, and you have a number of ways of processing that. EMDR, psychotherapy of all kinds, OEI, somatoemotional release, which is what we did, hypnosis, and so forth. Here's a person who had multiple sexual abuse from multiple family members. Same deal. The seizures are associated with the body's or the effort to block the emergence of those emotional events. Now, we do a lot of sleep assessments here in the clinic. We actually give the units for the people to take home to do 4 nights of assessment. This is what sleep should look like. You should have about 2 hours of REM and about 1 hour of deep wave. That's exactly what it should look like. These are waking periods. This is light sleep. Here's your deep sleep. Now, the deep sleep is when the body heals itself. The REM sleep is when the mind heals itself. Now, if you're deficient in REM, like this, the individual is not adequately processing trauma that's experiencing during the day. And when we often see that blocked trauma marker, this is what the sleep looks like. And if it's severe enough, this can kind of morph itself into pseudo-seizure disorder. So when we're treating this, we look at a lot of different areas here. What's the sleep architecture look like? Can we fix that? Release the trauma, help the person process the trauma, and so forth. Oh, this is just some idiot's comment that we got from somebody that there was no scientific evidence for the neurotherapeutic treatment of epilepsy. And the reason I put this up is I love George Bernard Shaw's quote, "Those who say it can't be done should get out of the way of those who are doing it." There's a huge literature on this. And some of it is in my book. For clinicians, you can have a look at the clinician's guide. It tells you how to do a lot of these things. And some of you folks are familiar with the public information services here at the clinic that Rita can tell you about.
Yes, that's correct. We do a lot of educational events for professionals and general public. As you can see on the slide, these include public lectures, our webcasts, grant rounds, and courses and workshops for professionals. Speaking of the workshops, the next one presented by Dr. Swingle is coming up in April this year. It is Clinical Q and Braindriving Fundamental Neurotherapy Workshop for licensed healthcare professionals. We will then offer the same workshop again in June, and we will do the advanced workshop in October this year. For more information, you can email me at rita@swingleclinic.com, and Kathleen, you can, I know you had some question. Please use that same email address and I can tell you what kind of unit we are giving to our patients for the sleep assessment. And for everybody else, same thing. If you have more questions, you can email me at rita@swingleclinic.com. Another workshop we have scheduled is for all mental health practitioners interested in working with transgender population and in developing confidence and competency to assist someone during and after a gender transition. The workshop will be presented by Lucas Walter, a founding director of BCFTM Network and past president of Trans Alliance Society. It is scheduled for Saturday, February 23rd. And on top of all the educational programs we have here at the clinic, there are online grant round sessions, courses, and webinars administered by Biofeedback Foundation of Europe. The professionals who complete these courses are eligible to receive APA continuing education units. More information can be received at BFE's website at www.bfe.org. And for those of you who are interested in reading some scientific literature on EEG biofeedback, the top sources are National Library of Medicine database and International Society for Neurofeedback and Research. All right, we came to the end here, so we hope you enjoyed the time with us, and we will be back on March the 9th with Hiroka Demichelis, an expert in optimal performance arena. We are very excited to have Hiroka on the show. So until then, have a great time. Happy Family Day, everyone. Bye-bye.